Graves' disease. It's also called as diffuse toxic goiter, autoimmune hyperthyroidism, and base dose disease in Europe. The Graves' disease is an autoimmune disease consisting of hyperthyroidism, goiter, eye disease, that is orbitopathy, and occasionally dermopathy, referred to as peritibial or localized mixed edema. All these are the important manifestations of Graves. What about the etiology and epidemiology of Graves? It is mainly caused by formation of thyroid stimulating immunoglobulin and thyroid growth immunoglobulin. So both are the antibodies or autoantibodies responsible for the development of Graves. And the Graves is most commonly seen in the woman between the ages of 20 and 40. So 60% concordance in identical twins and mainly associated with 𝐒𝐴_B8 and 𝐒𝐴_DR3. So what about the pathology and pathophysiology? As I mentioned, antibodies are formed against TSH receptors. So these are the two antibodies. These two antibodies act against the TSH receptors. So the thyroid stimulating immunoglobulin, which is the antibody, which binds the thyroid follicle, what you can see over here. So once it binds to the thyroid follicle TSH receptors, where it stimulates the thyroid hormone production. Because of this, there will be too much thyroid hormone production from the thyroid follicles because of the binding of this antibody. And the second one is the thyroid growth immunoglobulin, which also stimulates the glandular hyperplasia and leads to enlargement of the gland. So the long-acting thyroid stimulator called as LATs also has been thought to be a responsible factor for the hyperthyroidism of Graves' disease. So this is what you should know about the pathology. So in the Graves, what about the gross examination? The thyroid gland is symmetrically enlarged. What you can see over here, there will be a symmetrical enlargement of the thyroid gland. And if you go inside and if you try to see the microscopic examination or the microscopic picture of this Graves, the thyroid gland is hypercellular in nature. So hypercellularity is a typical picture of the Graves, where you can see over here very clearly that the follicles are small and wedged together with a little amount of colloid, and the interstitium may have predominant lymphocyte infiltrate. In the Graves' disease, there is too much crowding of cells. So this crowding of cells is mainly because of too many cells are produced, which means there will be a too much hyperplasia. So hyperplasia causes the crowding of the cells and later they develop papillae. So crowding of cells, formation of the papillae without fibrovascular core is a typical feature of the Graves' disease. Why I am concentrating more on the fibrovascular core? Because the presence of the fibrovascular core in the later stages of the Graves, especially seen in 5 to 10% of the cases, which is not a predominant feature, but it is considered to be a differentiating factor to identify the papillary thyroid cancer. That is the reason you should know that in the microscopic examination of the Graves, there is no fibrovascular core, but it is a predominant feature in the thyroid carcinoma. Next is the signs and symptoms. All the signs and symptoms are attributed towards hyperthyroidism because the Graves is a hyperthyroid state. So there will be anxiety, irritability, heat intolerance, weight loss despite normal eating habits. There will be a diffuse enlargement or a symmetrical enlargement of the thyroid gland, changes in the menstrual cycles, erectile dysfunction, frequent bowel movements, bulging of the eye, that is Graves' ophthalmopathy, thick red skin on the shins as well as on the top of the feet. That's why we will call it as the Graves' dermopathy, and a very important feature is a rapid or irregular heartbeat, that is palpitations. So all these are important factors or the clinical manifestations what you can see in Graves' disease. So what is Graves' ophthalmopathy? Not in all the individuals you will see Graves' ophthalmopathy. About 30% of the people with the Graves' disease show signs and symptoms of a condition known as Graves' ophthalmopathy, what you can see over here. And what is the pathogenesis in this condition? In Graves' ophthalmopathy, the volume of the both extraocular muscles and the retroorbital connective tissue and adipose tissue are increased. So due to cellular proliferation, inflammation, and the accumulation of the hydrophilic glycosaminoglycans, especially hyaluronic acid. So because this accumulation of GAG causes the change in the osmotic pressure inside the cell. Whenever there will be an increase in the osmotic pressure inside the cell because of the accumulation of the GAG, what happens is there will be entry of the fluid into the cell and accumulation of the fluid into the cell that can cause muscle cell swelling, predominantly muscle swelling. Because of this, there will be an increase in the pressure within the orbit that pushes the eyeball forward that can lead to Graves' ophthalmopathy, that is called as bulging eyes, and exophthalmos is a predominant feature what we can see in the Graves'. There is a gritty sensation in the eyes, and because of too much pressure is increased in the orbit, pain in the eyes is a predominant feature in the Graves' ophthalmopathy. Puffy or retracted eyelids, reddened or inflamed eyes, light sensitivity, double vision, vision loss, all are seen in the Graves' ophthalmopathy. And next, what it is? Graves' dermopathy. Reddening, thickening of the skin, most often on your shins or top of your feet, what you can see in the Graves'. Now, what about the clinical manifestations? Hyperthyroidism is a predominant feature what you can see in the Graves' and the most common cause of endogenous hyperthyroidism. The triad of Graves' disease. The triad includes hyperthyroidism, infiltrative ophthalmopathy, and infiltrative dermopathy, which is called as pretibial myxedema. In toxic multinodular goiter, one or more nodules becomes TSH independent. Exophthalmos and the pretibial myxedema are not seen in the toxic multinodular goiter. This is how you can differentiate between the toxic multinodular goiter and the Graves'. Next is the thyroid acropathy. So it is a digital swelling and the clubbing of fingers in the Graves' disease. And after discussing various clinical manifestations in the Graves', let us concentrate on lab findings. Serum TSH is the best screening test for the thyroid dysfunction. So in the Graves', you can see decreased TSH, increased T3, T4, and there will be diffused increase in the uptake of radioactive iodine. All the three are very important diagnostic manifestations in the Graves'. What about the complications of Graves' disease in this picture? So here, what are the pregnancy issues in Graves'? The possible complications of Graves' disease during pregnancy includes miscarriage, preterm birth, fetal thyroid dysfunction, poor fetal growth, maternal heart failure, and the preeclampsia. And what about the heart disorders? If the Graves' left untreated, and it leads to development of various heart disorders, especially palpitations and arrhythmias. And third one is thyroid storm. Thyroid storm, even though a very rare condition one can see in Graves' and seen in very small population, but it is a life-threatening complication of Graves' disease that is called as thyroid storm, also known as accelerated hyperthyroidism, or one may say it is thyrotoxic crisis. So this thyroid storm requires immediate emergency care. So the brittle bones are one of the important manifestations what we can see over here. So the diagnosis of Graves' disease can include increased T3, T4, increased uptake of radioactive iodine, and the decreased TSH. And the primary hypothyroidism, if you see. So even though the primary hypothyroidism is not a feature of Graves', but I want to tell you a few differentiating points over here. If you see the primary hypothyroidism, there will be a decreased serum T4 and increased serum TSH. If it is a secondary hypothyroidism, there will be a decreased serum T4 and decreased serum TSH. Now let us talk about treatment in Graves' disease. We have 3 treatment options available. One is thionamides, second is the radioiodine, and third is the surgery. If you take thionamides, there is a chance of permanent remission, but some patients avoid permanent hypothyroidism and low initial cost. And it has minor side effects like rash, hives, arthralgias, and the transient granulocytopenia. Not only that, 20 to 30% of the patients who are taking thionamides may get gastrointestinal symptoms, and all these are the minor side effects. If we talk about the major side effects of the thionamides, agranulocytosis, vasculitis like lupus-like syndrome, hepatitis or C. And there will be an important point to note over here that there is a risk of fetal goiter, hypothyroidism and birth defects if the patient is pregnant, and requires more frequent monitoring for any patient who is taking thionamide treatment. And the second option is the radioiodine. The importance of this, there is a permanent resolution of hyperthyroidism. So there will be a permanent hypothyroidism in the patients who are taking radioiodine therapy, and the patient must take radiation precautions for several days after treatment, avoiding contact with the young children and the pregnant woman. And the development or worsening of the Graves' ophthalmopathy is seen, and rare radiation thyroiditis may be seen under patients who are taking radioiodine therapy. And the patient concerns about long-term oncogenic effects of the radiation. And the third important choice is the surgery. So there is a rapid permanent cure of hyperthyroidism in this case. And even if the patient is taking an option of surgery, there is a permanent hypothyroidism, but risk of iatrogenic hypothyroidism and recurrent laryngeal nerve damage are important complications of a surgery. So this is what you should know about the treatment, and by this we concluded the topic called as Graves'.